From Faith Forward Media, this is Healthcare Musings. I'm Dr. Hashem Hasabala. Hey everybody, Hashem Hasabala here, another episode of Journal Club on Healthcare Musings. Happy to have you with me. Now, we're looking at an article published online on November 18th, 2024, and it's a systematic review and meta-analysis about correction rates and clinical outcomes in hospitalized adults with severe hyponatremia. Hyponatremia, low sodium level, we see it all the time, and sometimes people come in with very, very low sodium levels, and the great fear of correcting low sodium too quickly is that you get something called osmotic demyelination syndrome, where some of the nerves especially in the brainstem, lose their myelin sheath, and it can cause significant damage. And the most feared complication is something called the locked-in syndrome, where somebody is awake and alert but is completely paralyzed and cannot move. And cannot talk because it occurs in a very critical area of the brainstem. So this is the most feared complication of rapidly correcting serum sodium. And so they wanted to look and see, well, if we rapidly correct serum sodium, does it lead to poorer outcomes? So just to set up the study, the U.S. guidelines set limits of 10 to 12 milliequivalents per liter or less in any 24-hour period, and 18 milliequivalents or less in a 48-hour period, with more stringent limits of 8 per 24-hour periods in patients at high risk for osmotic demyelination syndrome. The European guidelines set limits of 10 milliequivalents or less in the first 24-hour period, and 8 or less per 24-hour period thereafter. And they mentioned that numerous large studies have evaluated the correction of severe hyponatremia, showing that consistently lower mortality among patients who received correction at rates exceeding current guidelines, and they didn't have worse or higher rates of osmotic demyelination syndrome. And so what they defined as severe hyponatremia is a serum sodium less than 120, or if it's less than 125 with symptoms such as cardiorespiratory distress, seizures, a Glasgow Coma scale of less than or equal to 8, or decreased level of consciousness. Okay, and so what they did was they broke it up into very rapid, meaning more than 12 per 24 hours, rapid, which is between 8 to 10 in 24 hours, slow, less than 8 or 6 to 10 in 24 hours, and then very slow is less than 4 to 6 per 24 hours. And the main comparisons was rapid versus slow and rapid versus very slow. Okay, and their primary outcome was mortality, defined as in-hospital and 30-day mortality, and secondary outcomes included hospital and ICU length of stay and 90-day incidence of osmotic demyelination syndrome. So they did this whole review and meta-analysis, and their findings were that they found that in-hospital mortality, adjusted in-hospital mortality, was lower in the rapid group compared to the slow or very slow group, right? With an odds ratio of 0.59, with a confidence interval of 0.45 to 0.76, with a probable dose response effect when comparing rapid versus slow sodium correction. And then in both meta-analyses, a more rapid correction was consistently associated with lower in-hospital mortality. They also found a lower unadjusted 30-day mortality, and a clear estimated dose response effect when comparing rapid versus slow sodium correction. Now, okay, so there was not lower mortality, which is very interesting. So did they have more osmotic demyelination syndrome? So they said 2 cases of ODS among 594 patients, which is 0.3%, occurred in the very rapid correction group. 18 cases among 3,842 patients, which is 0.5%, in the rapid correction group. 10 cases among 5652, which is 0.2% in the slow correction group, and 1 case, which is less than 0.1% in the very slow correction group. And these findings were not statistically significant, right? And there was a shorter length of stay, as well in the rapid correction group. And that makes sense, right? If you can fix the sodium faster, you can get the patient out of the hospital faster. And that's meaningful, right? Length of stay to a hospital in such a very thin margin business is cost. The faster you get a patient out of the hospital, the less cost is incurred. So in their discussion, they say that moderate certainty evidence showed that rapid correction, meaning more than 8 to 10 per 24 hours, was associated with 32 fewer in-hospital deaths per 1,000 treated patients, compared with slow correction, which they defined as less than 8 or 6 to 10, and 221 fewer in-hospital deaths per 1,000 compared with the very slow correction rate, less than 4 to 6. All right, so this moderate certainty evidence. And then low certainty evidence suggested that rapid correction was associated with fewer deaths at 30 days and may reduce hospital length of stay by 1.2 and 3.09 days, and it did not show that there was higher rates of osmotic demyelination syndrome. So this is important, right? That we get scared, and that these data seem to suggest that we can rapidly correct the serum sodium by more than 12, and it won't compromise our patient's safety. Now, they have to note that this only implies association and not causality, right? Okay, this is not causal, this is an association. And they go over, well, who cares? Why is a low serum sodium bad? And they go over it. They say hyponatremia leads to altered cellular function via osmotic stress and iotic strength, affecting apoptotic pathways and cytokine production and leading to oxidative stress. Hyponatremia could therefore contribute to increased mortality risk when in combination with serious medical conditions. It is well recognized that hyponatremia is an independent predictor for mortality, particularly in patients with comorbidities, and affects multiple organs. Treatment of hyponatremia is also independently associated with improved patient outcomes. So it is a big deal. We can't just blow it off. We should try to correct the hyponatremia as much as we can. And this study shows that we can be a little bit more aggressive in correcting the serum sodium without harming our patients, and this is great. This is potentially practice changing for me. Now, just a note about the limitations: these studies that were included were very heterogeneous, right? And then they also say that while slow correction was associated with increased adjusted mortality, it is possible that more patients in the slow correction group had increased severity of illness, such as advanced liver disease, heart failure, or cancer. And they mention a study from last year, 2023, where they found that slow correction of hyponatremia was associated with increased adjusted mortality in patients with liver disease, heart failure, and cancer. And they say, while we are unable to conclude that slow correction is the cause of increased mortality, rapid correction did not lead to worse outcome with increased mortality or ODS. And then they mention an additional limitation of the study is that ODS may have been underreported as it required confirmatory imaging findings. So these are important caveats. And at the same time, I think this study can give us relief that we can be more aggressive in fixing the serum sodium, and we shouldn't worry too much about causing this horrifically terrible and dreaded complication of osmotic demyelination syndrome in patients who present to the hospital with hyponatremia. Anyway, thanks so much for your time and attention, and until next time, Hashem Hasabala signing off on Healthcare Musings. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.